let's talk a little bit, Yelena, your approach to the first-line treatment in terms of a choice of metastatic regimen, and we're going to talk a little bit about sequencing, right? And so now we're metastatic, so we're not in a curative setting. So we're looking at first-line metastatic regimens. And tell me your thoughts in HER2 negative, but then in HER2 positive disease, does that change where you're going?
Absolutely. So to Ian's point, I think, if the patient recurs within 6 months of receiving a 3-drug combination therapy, it's a therapeutic challenge no matter what you decide to do. And this patient's disease is chemotherapy refractory. And so, with that, we will sort of put these patients in a separate, therapeutic challenge. And I'll focus on patients right now who are, present with de novo sort of metastatic disease, which in U.S. is a substantial percentage of our patients. I would say in my clinic, probably 50%, if not more, present with stage 4 disease at diagnosis. In the patient who is otherwise asymptomatic and has a relatively low volume disease, for HER2 negative disease, I tend to prefer a 2-drug combination. And again, to your point, it's a marathon, it's not a sprint. And majority of these patients continue to work full time. They feel well. And in fact, you probably saw at the plenary session, Ethan Bash's data presenting that with careful symptom management and tertiary nursing care and sort of early intervention, you can really get these patients through chemotherapy unscathed in terms of discontinuing therapy or dose reducing before they develop neuropathy, preventing needing for growth factor support with dose reductions and so on. So majority of the patients do well on that regimen. For the HER2 positive patients, really the standard has become the trastuzumab-based therapy, generally in combination with 5-FU and platinum. And again, in my hands, oxaliplatin is better tolerated than cisplatin, and generally that's what we prefer. For HER2 negative space, rainfall data will be coming out for the first line use of VEGFR2 inhibition with ramucirumab. And again, in unpresented data, no one's really formally presented it, but it looks like it may be an option for us in a first line setting. When it comes to second line setting, what it comes down to is a combination of patient symptoms. That's when it's important to have the molecular signatures on hand and not rush through, getting unstained slides, submitting things. So it would be useful to start it in first line setting. So when the patient comes to second line, you should know. In an MSI patient, absolutely, pembrolizumab should be done in standard of practice setting. And for HER2 positive patients, it's a real challenge because and this is data that I presented a year ago, and now others from Asia have seen this, observed the same. Loss of HER2 expression and amplification occurs in up to 20% of these cases. Not only that, now more in detail analysis of these tumors shows that they're activating other RTK pathways. So it's no longer a simple HER2 tumor, but they acquire KRAS mutations, amplifications, MET amplifications, and so on. So for the HER2 space in second line is in uncharted territory. TDM1 unfortunately did not show improvement in outcome compared to Taxol, and we really don't have a HER2 agent in second line that's standard right now. And so that's where we are. For majority of the patients in second line therapy outside of a clinical trial, and for MSS patients, Paclitaxel and ramucirumab remains the standard. And it will be impacted by the FLOT4 data. And, to give my 2 cents, I don't think use of Paclitaxel and docetaxel-resistant tumors should be recommended.
So I'm gonna tighten you down. So what fluorouracil platinum regimen do you use? And do you use an epirubicin?
So we recently put out a consensus statement with folks at MD Anderson, University of Chicago, and other centers, sort of academic centers across the U.S. in JCO saying that epirubicin should not be used in metastatic setting. So epirubicin is out. And so first of all, it's impossible to add biologic agents to 3 drugs combination. So which fluoropyrimidines I use, in short, Folfox is easy. It's modified Folfox 6 is what you use. Capecitabine is also a good option, particularly for patients who don't want to carry the pump and don't want to carry a Metaport. But generally, if I use that in sort of a frail or more nutritionally compromised patient, it's capecitabine 7 days on, 7 days off with oxali every other week. So it's not the, Zolox type of regimen, because those are still quite tough to use. I've attempted to use cisplatin 80 milligrams per meter squared as part of several trials, and it's not for the weak-hearted. You get 3 hours of mannitol, you get, renal insufficiencies in patients with normal creatinine at baseline. These are, fit 60, 70-year-olds. Their kidneys are, have been through a lot, so I would not recommend it.
Yeah, and as you alluded to, one of the things that's causing a little bit of a stir is the Rainfall study saying in a press release that it's met its primary endpoint, which was progression-free survival.
Right.
It wasn't overall survival, it was progression-free
Correct.
survival. But certainly the suggestion is our first line going to change sometime in the near future to add ramucirumab there, but I think a lot of it still remains up in the air.